Okay, this graph, quite important. We're going to dissect this in great detail. The only time, and this information sometimes goes unnoticed, and at some point when a medical student, a resident, a doctor, whatever is posed with such questions, they have no idea how to interpret this. So learn it now so that you'll never be confused. So let's set this up, and this is exactly what's taking place in your body. I love this graph, and you shall as well by the time we're done. Why? Well, let's take a look. On the x-axis, you have your plasma concentration of a particular substance, and there's many here. We have paraaminopic acid, we have inulin here, we have creatinine here, and glucose, okay? So those are the major ones that we will compare. And as you go from left to right, it means that the plasma concentration of that substance is increasing. Stop there, understand that. Good? Next, on the y-axis, we have clearance. You tell me what clearance means. Did it get filtered? It did, but that's a different definition. What gets filtered might be modified. What do I mean by modification? Go into the PCT. Meet me there? Good. Shake hands in the PCT. Excellent. Welcome. Next, then what kind of modification processes could take place in the PCT? Reabsorption. What's that mean? Removing your substance out of your urine, lumen, into the blood. Always, meaning always reabsorbing into the blood. Secretion is a second modifiable issue, and that means you're going into the lumen, correct? So that's modification. Depending as to the characteristics of the substances, pH, inulin, creatinine, glucose, then you will have certain changes that will take place with clearance. You tell me about creatinine already. With creatinine, it gets slightly secreted, so therefore you have your clearance, which is greater than GFR. We've discussed this a few times. We're going to bring this into play. Okay, now on the y-axis, let's say we have normal GFR at approximately, take a look at the y-axis, right around 100. We'll be hovering around there, okay? And as a surrogate marker, we'll be using creatinine as being an assessment of your GFR. And so we'll be right around that range, and where you see that being shaded between, let's say, 100, 120. Okay, so that'll be normal of what? GFR. Continue. So let's talk about each one of these substances, and you'll find this to be fascinating. Let's go to the one that you all are quite familiar with, and then what I'll talk to you about will be pH, and that gets a little tricky, but still doable. Very. Must be. Let's begin with glucose. So where is this? Well, we'll talk about clearance. Okay, clearance. Initially, as you take a look at glucose, which is the green line, on the x-axis, we have plasma concentration increasing from left to right. But Dr. Raj, I see that line being at 0 for a certain period of time for clearance. Why is that? What's clearance mean? It's the amount of glucose that you're getting rid of. There's no pathology here. So therefore, normally speaking, when you have glucose in your plasma, does it get filtered? Yes, it does. Right? And then in the PCT, how much of your glucose, or what kind of modifiable factor is taking place in the PCT? Is it reabsorption? Or is it secretion into the urine? What is it? Should you normally have, right now, normally speaking, when you urinate, and you did dipstick for glucose, should you find glucose in urine? Of course not. Now, if you have diabetes mellitus, then, I don't know what your situation is, but you get my point. Normally, you should never find glucose because all of it's being reabsorbed. Thus, for a certain period of time, you'll notice for glucose, the green line, that it is at 0. But now the plasma concentration is increasing. You tell me about your patient. Your patient is developing hyperglycemia. So therefore, there's diabetes mellitus now. Then all of a sudden, we'll talk about this in greater detail, is the fact that you start hitting renal threshold. What's renal threshold mean? It's one of the first signs of your glucose then appearing in your urine, right? It's one of the first times that you find your glucose appearing in your urine. Do not confuse your threshold with Tmax, right? And these are things that you've seen in physiology. And if you're weak there, then I would recommend that you review that so that you can work with me in pathology. So here, you have hit threshold. Oh boy. Now, you see that green line increasing and doing what? increasing on the y-axis, which is what? Clearance. So now you're finding a little bit more glucose, a little bit more glucose, a little bit more glucose in the urine. Okay? Please continue. Please continue. And as you do so, you'll find that you have glucose, which is increasing in plasma concentration, so much so. And you might have hit now Tmax, let's say at 370. And it is getting close, very close to normal GFR. But, your next question, and I'm just going to ask it to you here so you start pondering it. And when the time is right, I am going to elaborate on this because right now it's about giving you an idea of this graph. Why is it that glucose in that line, no matter how high your plasma concentration of glucose gets, it is always going to be below GFR? Clearance of glucose is always going to be a little less than GFR. Why is that? If you can answer that question right now, you're in fantastic shape. But if you're not, that's okay. I like to tease a little bit, as you know, and at this point, it's just so that you understand this graph. So your question at this point is, you're asking yourself, even with the glucose level being at 370, and with all this glucose being in the urine, it's still going to be less than GFR. Amazing. Why? Because you could talk about those glucose transporters, and every one of those glucose transporters in BCT is still trying to reabsorb. They're not damaged. Okay. Stop there. So that's for glucose. Now we talk about creatinine, and, well, there you have your inulin. And that inulin there is whatever is GFR is pretty much equal to clearance. So therefore, as inulin is filtered, as it goes to the PCT, none of it is reabsorbed, none of it is secreted. Whatever is filtered is cleared. So therefore, inulin is the perfect theoretical substance. Do not confuse the inulin. That is not saying insulin. That is not a typo. Inulin. Inulin is the perfect measure of GFR. So therefore, clearance in GFR will be the same. Are you loving this graph? A lot of information, a lot of integration, but you're doing this. Finally, we have pH. Paraminoperic acid. Walk me through pH. What do you know about pH? It measures, you tell me. Use the P to your advantage. Or PF. Renal plasma flow is what it equals. Now, do you remember from physio what normal renal plasma flow is? It's 600. I want you to begin at the afferent arteriole. You're at 600 renal plasma flow. What's your filtration fraction? 20%. So I've taken out 120 from the 600. What are you left with? 480. Where is that 480 remaining? In the efferent arteriole. Are we clear? Do you understand how important terminology is here? I know it's intense, but let's walk through this. Luckily, you can pause me for a second, take a breath, and continue. So here's your 600, and you have 120 filtration fraction. You're left with 480 in the efferent arteriole. And what are you going to use pH for? You're using pH to measure renal plasma flow. If everything's perfectly normal, then what should your measurement of paraminoperic acid be for renal plasma flow? 600. Dr. Raj, how in the world am I going to use pH as a measurement from the urine to measure renal plasma flow? How am I going to do that? Or how are you going to do that? What's the physiologic process? Because as you get into the peritubular capillary, are you there now? Peritubular capillary. What must you do for every single one of those pH so that when you measure the pH in the urine, it tells you, oh, renal plasma flow is 600 in this normal patient. Every single paraminoperic acid, or hippurate, must be secreted into the urine. So thus, when you do find it, that it's measuring renal plasma flow of 600. I want you to now come to point 0 for pH. At pH, plasma concentration is quite low. And the red line there, for a certain amount where plasma concentration at pH is at very, very low levels. 0. Oh, slightly increasing. For low levels of paraminoperic acid or hippurate, it is going to be completely secreted, thus giving you a renal plasma of 600. But Dr. Raj, why is it that pH is now decreasing? Why is it that the clearance of it is decreasing? Well, this is a question that you get. There was an experiment in which you had a bunch of students that were injecting a mouse with tons of pH. Tons of pH. When pH is in abundance and plasma concentration is ridiculously high, I want you to go all the way to the right side. And I want you to take a look at that red line. It is almost equal to your GFR. And that's what happens physiologically. When you increase the plasma concentration of para-aminobutyric acid to the umpteenth or extreme level, it will almost equal GFR. But at low levels, it's almost perfectly equal to 600. You've understood that much right now, and if at any point in time you have a little bit of a question, either get back to me or review your physio, because I need you to know at least this much so that I can feel comfortable walking you through some important pathologies that are going to come in and dealing with glucose, dealing with creatinine. Okay, renal blood flow. What is it? It's renal plasma flow plus your non-plasma blood. What's your plasma? Your plasma is going to be minus your RBCs, and it has many of your coagulation factors, and it has proteins. Clear? What are you going to use to measure renal plasma flow? Para-aminobutyric acid. At what plasma concentration? Just concept. Low plasma concentration of pH gives you perfect approximation of renal plasma flow. What is renal blood flow? It is renal plasma flow divided by 1 minus hematocrit. You tell me what normal hematocrit is approximately. Use 40, you'll be fine. Okay? 40. What is hematocrit? You take a test tube, you do a centrifuge, and what ends up at the bottom would be the concentration or percentage of your RBC. It's a sediment. So what is renal plasma flow? We just got done talking about this. Clearance of substance completely cleared by single pass. Welcome to pH. Talk about that filtration fraction. Guess what we're going to do? We're going to use that clearance formula. Do you remember what that was? Ultraviolet over P. UV over P. So, before we begin though, close your eyes. What's filtration fraction? GFR over RPF. Stop there. You tell me, what is the perfect measurement, theoretically, physiologically, for GFR? Perfect. Inulin. What do you use clinically? Creatinine. Are we clear? You as a doctor, you as a clinician, will use plasma creatinine to measure kidney function or to measure GFR. Now, physiologically, you might get questions in which you want to use inulin. That's the perfect theoretical substance. Okay, so if we're going to use GFR and we're going to use inulin, take a look at filtration fraction, and it's equal to the clearance of what substance? Inulin. Stop there. Then we have RPF. What did you and I just talk about as being a good measurement for renal plasma flow? PAH. Okay? And with this, take a look at the denominator. RPF, clearance of renal plasma flow. Or, para-aminobutyric acid. What you do next, if you're given information, is that with that clearance, what's the equation for clearance? UV over P. So what are you going to do for GFR? You're going to take a look at, step by step, urine concentration of whom? Inulin times the flow rate, UV, over P. Plasma concentration of whom? Inulin. Because what are we measuring? GFR. You'll do the same concept for clearance of para-aminobutyric acid. What's the normal filtration fraction? 15 to 20%. You'll be fine to use 20%.